Basically, I think it's time for precision medicine now in CLL, because not only do we have lots of different treatment options for patients in first line and also in relapse refractory CLL, but more importantly almost, we have got the right molecular diagnostic tools, so that the tools in the laboratory to identify the biological differences that we see in CLL, and to see how some patients with difficult CLL will respond to some particular type of treatments in a better way. So it's all about precision medicine, giving the right treatment to the right patient at the right time, really. So the difficulty with this is how we're going to apply those new technologies, in particular next generation sequencing technologies, in the diagnostic laboratories, and that's to do with sometimes to do with practicalities and whether we can get the samples quickly enough to the lab, but it also has to do with standardization of testing, making sure that we assess in a very robust way sensitivity, specificity, of the diagnostic tests. And so really part one of my talk was about highlighting a little bit about where we are with the with TP53 mutation detection, where in the past we only looked at this by using something called fluorescence in situ hybridization, so FISH technology, where we looked at bits of chromosomes missing that led to a deletion of TP53. And then more recently, sequencing showed that there are mutations in TP53, but then even more recently, we see that small level of mutations in TP53 also confer poor response to chemoimmunotherapy. So for that, we need more sensitive technologies to diagnose these robustly and reliably in the lab, and that's next generation sequencing. Only next generation sequencing can do that in a robust way. So clearly already with a predictive marker like TP53 that we've had for a long time, that we've used for a long time, both in clinical trials and also in clinical practice, we see that the technological revolution in the laboratory changes how many patients we can detect with that abnormality, and that's clinically relevant. And obviously that requires, adaptation of diagnostics and standardization. So then the second part of my talk was all about how we can expand this further, because at the moment when people are using next generation sequencing in the lab, in the diagnostic labs, it's primarily targeted sequencing. So we're looking at a few genes, and then we look at this, at these genes at low level mutation detection. That's already a lot, progress and tremendous progress. But we can expand further of that, because if we're sequencing the whole genome, then for the first time we have an unbiased view on the whole story of genetic changes in CLL. And so what I was trying to do with the second part of my talk was illustrate some of the potential of whole genome sequencing, in particular around the detection of areas in the genome that we don't reveal, and that we haven't really revealed even in important studies such as the CLL sequencing, CLL8 sequencing with the Dana-Farber group that used whole exome sequencing. So we essentially now going into areas of the genome that nobody has ever looked before to see whether there are mutations, relevant mutations in those areas of the genome that might help us predict why some patients do badly and other patients do better. And so those areas of the genome that nobody has ever looked into represent 97% of the genome, whereas the exome is only 1 to 3%, depending on how you count it. So there's clearly a tremendous potential of novel discovery and detection. The difficulty will be to assign and understand what those mutations mean when they're in regions of the genome that don't code for proteins. And that is work that I think everybody's currently interested in. But I very strongly believe that if we want to go from a stage where we are currently, which is we're personalizing medicine, we're deciding on treatments of, on the basis of clinical fitness of patients and whether they have got side effects, whether they have got other comorbidities or not. We will be if we want to make further progress, we need to be more precise about the way we are characterizing the CLL cells themselves and their biology. And we can only do that by using unbiased approaches such as whole genome sequencing. So that's really where my focus is coming from. And I gave a few examples of why I think this is important.